Hello everyone and welcome to this webinar about a StepChange Framework. I hope you all had a really inspiring morning already. And I would like to introduce today's presenter, John de Pury. And John is the Assistant Director of Policies at Universities UK. And he's one of the founders of the StepChange Framework, a framework that educational institutions support in the development of a broad approach to mental health. John is going to tell us more about his hands-on model, and it is an inspiring model, and it's interesting to know how we can translate it to the higher education in the Netherlands. We are with a lot of participants today, but we will try to make the session a bit interactive. So I would like to ask you to use the chat for any questions or any comments. And during the session, we will ask John to answer some of the questions. So for now, I'm happy to give the floor to John. So John, please unmute your microphone and go ahead.
Thank you, Marjolaine, and thank you all for welcoming me today. We're in a strange position at the moment, aren't we? Sort of 6 or 7 months into the tunnel of the pandemic, with probably at least another 6 or 12 months to go, and nothing more important than the subject we're going to talk about today. So as Marjolaine says, I'm the Assistant Director of Policy. Actually, I've just been moved sideways, Marjolaine. I'm now the Associate Director of Policy at Universities UK, and I have the slightly unenviable title Head of Health, which in the middle of a global pandemic is a big responsibility, obviously. So there I am. Universities UK, the organisation I work for, represents 139 of the universities in the UK. Now, that's not all of them, actually. There are about 170 universities in the UK, but the ones that we don't represent are really the small and specialist organisations. We do represent all of the technical universities, so the old polytechnics. We don't have 2 associations representing the sector in that way. Now, obviously, you will know from your safe distance that the UK is a complicated country at the moment, into 4 countries. And we represent universities across all 4. But that does make life difficult sometimes because policy is diverging across those countries, and particularly education and health policy. What that means, however, is that we have across the UK in our membership about 1 million students. It's a really significant health population, and almost 500,000 staff. So 2.3 million students and 500,000 staff. And I'm looking forward, as Marjolaine suggested, to understanding how we can use the framework that we very much developed for our sector, thinking about how we could, you could adapt it for your requirements as well. So I thought what I'd do today, and as interactive as we can be, because I know that in the last 6 or 7 months, we've all been staring at screens and giving time to these little tablets in front of us. I thought what I'd do is break it up into 4 sections, starting off with a big section about step change, the vision and the framework, and then a break for you to discuss the framework with me. Then something about the enablers for the improvement process that we know needs to take place if outcomes are going to be improved. Finally, to think quickly about a couple of areas of real strategic focus, and those are the transitional periods, actually how we join up thinking about a life course in terms of mental health and well-being, from early years through schools and colleges into university and across into the workplace. It all links up. And of course, that really important strategic focus about how we work with our health services, in my case, with our National Health Service. Finally, I'm going to spend a bit of time thinking about how COVID-19 and the pandemic has challenged us all, has brought particular impact, but also is providing us with some real opportunities for strategic prioritization and for change, the change that we all want to see. So I wanted just to, and for many of you, this will be, I guess, a familiar frame, but I wanted to step back a little bit and think about universities as health settings. We tend to get very focused on support services within universities, but of course, universities and all educational settings are also health settings. If we look at those determinants of health and well-being set out in that diagram on the slide in front of you, you can see that universities or education settings actually can influence much more than just the support services. Now, we know that mental health, health in general, but mental health in particular, is determined by a wide range of individual, interpersonal, community, environmental, and structural factors. And the opportunity for us as universities is to influence many of those for a really significant 3, 4, 5 years in our students' lives, to really change outcomes for this significant part of the young adult population. In the case of the UK, about half of all school leavers now go to university. So if we can influence their mental health and well-being outcomes, we're really changing outcomes for our nation. When we first set out StepChange, we really needed to, I could say we started the process in 2016. It's almost exactly 4 years ago now. And we really did need to make a case for action. Now, I suspect that I'm talking to a community of people who completely understand this first case for action. Across our 2.3 million students, the vast majority of them are in that young adult age category, where we know that onset of lifelong chronic mental health conditions is particularly sharp. So 85% of our students are in that young adult category. We know from NHS data that approaching 17% of 17 to 19-year-olds have a diagnosed mental health condition during that period. But we also know that only 6% of arriving students disclose a disability of any kind, including mental health. Actually, mental health rates as the second disclosed disability amongst first-year undergraduates in the UK. So there's clearly a real issue with this population of onset of chronic mental health conditions. We also, as I'm sure you are in your institutions and in your settings, particularly focused on the tragedy and the challenge of suicides in the student population. The last year that we have data for in the UK, in England and Wales, in fact, there were 95 deaths by suicide, 95 students who took their own lives. This, of course, has a huge impact across friends, family, wider student and staff populations. In fact, as we will come to later in my presentation, universities have quite a protective effect in terms of suicide. This 95 deaths in 2016 these 95 deaths are occurring at a lower rate than age-adjusted populations. But every death by suicide is one death too many, and it's a real focus for us in the sector at the moment. As well as that responsibility for action, there's a real opportunity for action. And we know, of course, that mental health and well-being underpins learning, it underpins student success, it underpins staff well-being, engagement and performance. We know that researchers, if their well-being and mental health is good, are doing much better research than if it's poor. There are so many things that we can influence for the positive here. So just a bit of data for you there. Those with mental health conditions are much more likely to drop off their courses. So there's a real issue about retention and continuation of courses. And the longer term impacts of this are huge. My friends at the Mental Health Foundation do a lot of work influencing the UK government about the financial and social impacts of mental health and mental illness. So they reckon about 12.1% of the UK's total GDP is dependent upon good mental health. So how did we get here? And I won't spend long with this, but my slides will be with you all after the talk. And all of these links are working. As I said, we set off on this journey in 2016. In 2017, we'd commissioned a piece of really foundational research, not by degrees, by the Institute for Public Policy Research, which set out a real snapshot of student mental health at that point in time. In 2017, alongside that research, we published StepChange, the first version of our strategic vision and framework. We then piloted StepChange, this strategic framework, in 3 universities in England and Wales. In fact, StepChange was being implemented in many more universities across the country, but this was a formal piloting process, and the evaluation of that pilot will be written up and published shortly. In 2018, we published 2 linked frameworks. The first was a framework specifically about suicide prevention, suicide safer universities, which sits within the StepChange framework. And the second was, if you like, a whole system framework to sit alongside our whole university framework. Minding Our Future looked particularly at the links and the joint working, the partnership with the National Health Service and the care services. Now, as I'm sure it is in Holland, this is a very busy space in the UK. And our close partners, Student Minds, the student mental health charity, have started to develop a university mental health charter. This is really based on our strategic framework. It aligns with it absolutely. There's no confusion there. And they published their first version of the charter at the beginning of this year. And as Marjolaine and others know, we published StepChange, the refreshed version of our original strategic framework, in May this year. In fact, we launched the StepChange framework in March this year, just at the beginning of March. We'd invited 2 UK ministers to come to the launch. One of them was already isolating, COVID positive, and a couple of days later, the whole country went into lockdown. I'll come back to that in the final section. So moving through this, I don't know how many of you have had a chance to look at the StepChange, but I did want to set out that really what it does is provides a vision and a call to action. And our vision is very much a whole population vision, that universities should transform themselves to be places that promote mental health and well-being, enabling all students and all staff to thrive and succeed to their best potential. And we know that the route to arrive at that vision, and we don't think this is a 6-month vision or a 5 or even a one year or 2 year vision, it's probably more like a 5 or 10 year vision. But in order to achieve it, we need all universities to adopt mental health as a strategic priority, to embed it across everything that we do. And that means implementing a whole university approach. This graphic here really sets out our version of the whole university approach. I fully expect other sectors, actually individual universities, to take this, to tear it up, to reshape it and to create their own version of the whole university approach. We're not proud about this at all. We want you to take this and use it in the way that you see fit. Our whole university approach thinks about the university in terms of 4 big domains. And I'm going to run through very quickly what we think needs changing in each of those domains for mental health really to be as a priority. And then I'm going to stop for some discussion and questions. I want to return to this idea of universities as healthy settings, settings that can influence the good mental health and well-being of whole populations and staff and students, but also have a significant responsibility to support those with existing conditions and to mitigate risk for those in mental distress or at risk of suicide. So to achieve this must be a strategic priority. It must be about open conversations, effective support, early intervention, and a new emphasis on prevention. Our paradigm in mental health care, and for full disclosure, I worked for many years in the National Health Service before joining the higher education sector. But our emphasis always in healthcare is on health services rather than on prevention and early intervention. And as education settings, we have opportunity to lead this new paradigm. So what are our 4 big domains? First of all, what do we do as universities? We're places of learning, places of knowledge. And if we don't embed mental health and well-being in everything we do as places and communities of learning, this is really where we need to start. So re-examining curriculum, pedagogy, assessments through a mental health lens. Thinking about the building of learning communities that are from and for students. Thinking about student self-efficacy and resilience. Thinking about how when students are getting into difficulties, we assess their fitness to study, or in the case of healthcare students or teaching students, their fitness to practice. The next big domain, of course, is how we support those getting into difficulty. I think I know that in Holland, as much as in the UK, we've ended up having something like a parallel health service in universities. We've really tried to meet student needs. When we do that, we need to deploy best evidence and best approach to understand and we must co-design our services with the students who'll benefit from them. They must, of course, be effective and efficient and subject to regular audit to establish that. They must be properly invested in by the university, so they need to be properly resourced and staffed. They also need to be accessible to all students, and I'm sure your student population, like ours, has become increasingly diverse. So they must have appropriate services to the different kinds of students who need them. Now, when we published the first StepChange, we talked about staff, but we really didn't think through what the implications were. But staff and student mental health, as I'm sure we're all feeling at the moment, are absolutely interconnected. And in our new refresh StepChange, this is a particular focus for us. Some of you may have heard of Mind, the mental health charity who focus particularly on workplace well-being. And we're working particularly closely with them around their mental health at work commitment. We know that mental health is more opaque, less visible to us, but possibly more challenging than student mental health. We know that there are structural as well as cultural interventions that need to be made. We know that staff are well, I'm sure I don't need to tell you, staff are working too hard. They're working long hours. I quite often will have academic staff answer emails at 2 o'clock in the morning or 2:30 in the morning, and then up again at 7 or 7:30 the next morning and back on email again. We need to think about staff mental health for itself, but also in terms of how staff support students, not just in the professional services staff, such as this community, but also academic staff, who of course are the front line of working with students. Finally, and I'll pause after this, thinking about not just a whole university approach, but a whole environment, whole system approach, because we know that students actually, particularly residential students, and 75% of that 2.3 million students in the UK go away from home to stay as well as study at university. And we know that whole environment of where students live, their transport, their sports facilities, and so on, are incredibly important to their mental health and well-being. So thinking within what universities can influence in local communities, how we promote health, how we promote safe and supportive cultures, how we think about the architecture of student accommodation so it promotes good health, how we work with providers of accommodation to make sure that's happening, but above all, how we support safe and supportive communities within our student and staff populations. Well, I think that's a lot to take in, and thank you so much for your attention to this point, but I'm really happy to take any questions at this stage before we go on to the next bit of this presentation. Marjolaine, shall I hand back to you?
Yes, that's good. So thanks. Thank you very much so far. Really interesting. So for the participants, if you do have any questions, please use the chat. I don't see any questions yet, so maybe I will ask a question. You were talking about interventions, structural and cultural interventions with the staff part you were talking about. Could you maybe give a concrete example to make it a bit more concrete? Yeah.
Yes, I mean, absolutely. So I think we're all very familiar with the cultural interventions, the kind of anti-stigma campaigns, the kind of open conversations, perhaps work on staff well-being and resilience through training and so on. We recognize these are significant, but we also know that pay and conditions and workload and job design are really significant determinants of mental health. Now these are pretty sharp areas for discussion. I don't know if you know, but the UK sector, there's been ongoing industrial action from one of the staff trades unions in the UK sector, and that is around pay and pension conditions, but it goes much wider than that. I think one of the things that Universities UK is very interested to do at the moment is to have an honest, non-adversarial conversation about what needs to happen with structural conditions, particularly in light of COVID. People are working harder and longer hours than ever before to improve staff well-being. And to give you the specific example about that, how, for example, we think about interim job design so that it really reflects what staff are doing. We know staff have spent a lot of their spare time moving courses online so that students can keep getting their education. But that's really seen as extra to their work. And we know that staff are already exhausted at the start of the academic year. So how do we respond by redesigning jobs for this particular period and really thinking about staff resource in the context of that? Thanks, Marjolaine.
Yeah, thanks as well. And there are some questions in the chat. So because of time, I will choose some of them. One, I think, concrete question: from where came the initiative of the StepChange Framework?
Yes, that's a really interesting question, because of course there's been work on student mental health since the 1960s. People started thinking about it then, particularly around student suicide, but it was always led in two areas. And the first was by student activists and the other was by professional services staff and clinicians, those on the front line of care. I think what happened in 2016 is that so the organization I work for represents the university leadership and the universities that they lead. I can say that when I arrived at Universities UK, mental health was seen as a reactive policy area. When there was a difficulty, we would respond to it in a press release or whatever. I think I understood with a couple of very proactive vice chancellors that this required taking hold of. And so with those student activists and the professional services staff, we did a scoping exercise about where we should take it as a strategic priority, and understood that we should start developing this whole university response. So I would say university leadership are only just coming to this in the last few years, but let's keep the pressure up on them. Let's keep the momentum going.
Absolutely. So, and what kind of changes should be made in the curriculum design? Which, for example, smaller student groups and more time for teaching and studying be a solution? Is one of the questions.
It's a really interesting question, isn't it? Because, of course, with COVID-19 and COVID-safe teaching spaces, we're anyway having smaller groups. They are socially distanced. They are starting early in the morning, later. But we're already hearing from students that they like those smaller groups. They're less interested in the big lecture settings. We're already hearing from some students that they really like the blended learning as well. They like the opportunity to stay in their home and do the study that they need to, and to come in for the essential face-to-face and the interaction with the teachers. So I think, I mean, there are so many ways that pedagogy and curriculum could be changed. I'm very interested in some of our smaller members where they have simply, even before COVID, stopped using lectures, big lectures, as a pedagogic method, and use only small group settings. They have reported much better rates of student well-being. Now, that might be for many other reasons as well, but certainly they would signal their different pedagogic approach as key in that.
Right. Yeah. Sure. I think one more question for this moment, because of time. You mentioned like the promoting self-efficacy with students and staff. Could you maybe give some examples of how this could be done, in your opinion? What should change?
Yes, I mean, I think one of the real challenges we face, and I'm sure this is something that you talk inside your group about, is that, and it's particularly true in the pandemic, is we must not medicalize normal stress in the student or the staff population. We know that stress, as opposed to anxiety, is a natural response to challenge. So we have to support students to deal with stress. And I mean, certainly there are growing numbers of universities across the UK who are putting modules into every curriculum which are about self-efficacy. They are about psychosocial learning. They are, in some instances, about the practice of mindfulness. They are about teaching and learning methods, how to learn effectively, how to use your time effectively. I think all of these build self-efficacy, whether they are at the psychological end or the social or the learning end. They all work in a continuum to develop self-efficacy.
Yeah. Okay, thank you so much. There are some more questions, but I think maybe we can continue with your presentation and then we'll keep them for the next discussion part.
Brilliant.
Is that okay?
Brilliant. That sounds really good.
Okay, perfect.
Thank you, everyone, and thanks for very engaged and good questions. So we understood, to come back to the whole university approach, that we needed really to not just think about what a whole university means, but about how change happens across these complex organizations, these complex institutions that universities are. And again, we very much invite you to take what we've set out in our framework and to reshape it according to your needs. But for our settings, we understood that 5 core enablers would drive the change, would allow our vision of what a mentally healthy university should look like to be realized. And I'm going to just take you very quickly through those 5 enablers and then talk in a little bit more detail about the one that I deal with my constituency, which is the senior leadership and the vice chancellors, principals and rectors. So let's start off looking across all of those enablers, and really happy to come back to any of them in more detailed discussion. We know, of course, universities are not really like big corporate businesses. They are more diffuse. They have many different centers of power within them, not least the senior academics, student leadership, and so on and so on. But we know without senior leadership emphasizing mental health and well-being as a strategic priority, change will not happen and will not sustain. Without senior leadership assigning this as a priority, dedicating focus and resource to it, these changes will not sustain. But we also ask that leadership is part of the open conversation. It's really striking to me still, having come from work in the NHS and before that in business, that there isn't a single vice chancellor in the UK who discloses a mental health difficulty, who discloses a personal or even a family difficulty with mental health. Now, that to me is very striking. In our top companies, there are many, many chief execs now, at least 10 or 12 I can think of, who disclose mental health difficulties. In the NHS, there are probably, again, 10 or 12 chief execs of NHS trusts, the big hospital groups, who disclose mental health difficulties. But there's not a single vice chancellor. Striking. As well as those open conversations, and I think there was a question about this earlier, creating the supportive and safe cultures that allow people to disclose and seek help is a leadership responsibility and role. And then finally, leadership have got to be responsible for some of those big strategic partnerships with the health system, with schools, with employers. We'll come back to those. Going through the other enablers, we know, I mean, you will know as a professional community that co-production with patients, with students, with staff is critically important to not just in terms of service design and delivery, but also in terms of how you set a shared vision and the strategy that you build to achieve that vision. In the UK also, one of the things, and it was a real source of activism in the early days of our work, is the amount of peer support and formally assessed peer support networks that students developed. And those continue to be a really significant source of insight, but also source of energy to the change. Of course, what we're talking about here is an improvement journey, and improvement doesn't happen without data, without a baseline to start from, and without data to show change. So really thinking about shared data, common records, analytic systems that would support effective use of data, some real challenges around how we share data and records with our health system. We're all subject to the European data protection regulation, and we know that when data, particularly sensitive personal health data, travels from the health system there are many restrictions on it being used by university support services, but that gap in data also represents a gap in care as well, and potentially a high risk gap in care. We've also been very focused in the UK in the last few years about how we think about the wider informal support for particularly student but also staff mental health. We know that it's good practice in mental health care generally to involve family and friends with the consent of the patient. And it's been a particular issue for students, and particularly for students in mental distress or with suicidal thoughts, that universities have been very, very reluctant to reach out to family, to obtain consent to reach out to family. And a number of bereaved parents of students who took their own lives have been working with us and indeed with health professionals on what's the appropriate way to share information and to bring in these informal support networks. Really happy to discuss that with this group. It's already been raised actually in the chat, but as our student population has grown, it's grown in diversity and diversity of all kinds. So we think in particular in the UK sector about how we meet those diverse needs. We know, for example, that LGBTQ+ students are particularly vulnerable to mental health difficulties. So we need to have services, support services that really are accessible and appropriate to those students. Otherwise, they simply don't come and access them. Similarly, with students of Black and minority ethnic backgrounds, we need to have support services where, for example, a Black student can go in and actually see a face which gives him or her the confidence that his particular cultures and needs will be understood and met. And there's a lot of work in some of the more progressive universities in the sector about how that happens. We need to think about targeted interventions for those subpopulations of students, and we need to think about appropriate accessibility. This, of course, has to sit within the wider work I think we're all interested in, which is about how we make our sector more equal, more diverse, more responsive to the 21st century rather than some 19th or even 19th century or even older notion of community. Now, finally, I know this will be interesting for this group. We must base everything we do on good principles of research and innovation. We must generate effective evidence of demand and need. And it's really interesting to me that a lot of the narratives about student mental health were based very much on the poorest kind of research. And I think we're starting to address that in the UK sector, and that's happening globally as well. I was earlier this year in Melbourne in Australia with Origin, the mental health organisation there, looking at a new framework that's being developed for the Australian sector. And they are really, Origin are always very focused on the evidence base for any change. And it's really gratifying to see this happening across in other global sectors. We must assess the interventions that we put into place, just as we would in a health service. The fact that we have a parallel health service in our universities doesn't mean that they should escape audit and evaluation. And we must have an approach to emerging good practice that allows innovation to happen, just as we do in healthcare. Now, we're very lucky in the UK. 2 government-funded networks, a What Works Wellbeing Centre, which is a national centre funded by our public health authority, that we worked with to set up a platform on mental health in higher education. That looks at really emerging good practice, but we're also very lucky to have a specific mental health research network based at King's College London, really high grade researchers leading it, very good integration with students and student users. It's built in partnership with Student Minds, the student mental health charity. So we're very lucky to have a good practice network in the What Works network and in Smarten, the research network. I think, Marjolaine, I might stop there because I'm sure people will have a lot of questions to ask after those enablers set out. Actually, what I'll do is I'll just go on one more slide, if I might, and just talk very quickly about the work we're doing with leadership. So I think this was a real challenge after we developed the first version of StepChange. We had, you know, in the way these big paradigm shifts quite often work, we probably had 6 vice chancellors who really got what we were talking about, what we were asking for. But 6 out of 139 is not a great percentage. So our real focus over the last few years has been to get at that senior team, to understand why it is they don't understand the paradigm shift, and to make the case to them, to support them, to understand the changes they need to lead. And we asked them some very simple questions, which I've set out on this slide. And of course, you know, no is the wrong answer on this slide. We go beyond that now. We're now working with some, I have to say, really excellent corporate consultants. And it's not often I put those words together, but who their kind of specialism across the world is to work with the big corporates and to think about health as a priority for leadership teams. And they've given us, we're very glad to say, some pro bono time to work with vice chancellors and senior teams exactly on this issue. We've now got 8 senior teams signed up to designing a leadership tool, which really is about leaders having open conversations, understanding a 5-year horizon for health in their institutions, thinking about the different components of what they need to do as leaders in order to deliver these changes. Marjolaine, I'll stop there.
Thank you. So you were talking about, of course, the strategic priority vision, and another question is like about creating the context in which like this framework can flourish. Could you maybe add a bit more?
Yes, I mean, I guess that's exactly what the enablers are really designed to say. So we have the framework, which is the 4 pillars, you know, learn, support, live, and work. Thinking about to sort of making sure you think about everything a university does and influences, but actually how do you implement those changes? Now, coming out of health as I do, I'm very familiar with the idea of quality improvement in health. And I think that idea of change where people are empowered within organizations to drive change in their groups, in their communities, is appropriate to universities. These quite diffuse organizations. These are not like big supermarket chains. You can't sit in a central office and pull a lever and expect things to happen. You have to bring people with you, and you have to empower people to make the changes. But that needs to be done within a framework so that we're all heading in the same direction. So my simple answer to the question is the 5 enablers will create the right conditions for the improvement to happen. But I'm really interested in your challenge back to that. I, as I've said, I work particularly on leadership as a key enabler, but I definitely don't think it's the most important enabler. I think they all need to be balanced.
Exactly, yeah. So, and you were talking about data when you were talking about the enablers. And the one question is, how do you solve the data gap?
Yes, I mean, you know, I'm still, I think that's a piece of work that we're still really struggling with, because there are multiple data gaps, aren't they? There's the data gap within universities. So, for example, when an academic staff member understands that a student is doing badly, how are they really closing the gap with support services so an intervention can be made? Are there other ways to do this? And I'm part of a project based in 5 universities where we're looking at digital analytics, usually used for learning, to show people's learning progress, but thinking about how we can use analytics for well-being. So for example, if someone doesn't, I mean, I'm sure you will, many of you will also have smart campuses where you check in and out of bits of the campus, or you check on and off the virtual learning environment. If a student kind of disappears off the radar for a few days or 10 days or 2 weeks, is there an intervention that should be made? How do we know? And with digital analytics, we can know pretty quickly about that. And then what are the appropriate levels of intervention? And we're working, as I said, with 5 universities on thinking about that, both in terms of suicide prevention, so understanding where students are really going off the radar, but also just in terms of when students are not doing well in their well-being and how we can nudge them up. So for example, if someone has dropped off on their academic performance, how do you support them with psychosocial interventions to lift them up again? So I think that's the first data gap. Sorry, I'm taking too long to answer this question, Marjolaine, but that data gap within universities, which actually I think is the key one that we can solve. A thing that I'm working on very strongly at the moment is how we address the data gap with healthcare. And I think in particular, that is about permissions, making sure that the legislative and regulatory framework doesn't stop good data transfer. And I think we're reaching it in the UK. Systems and people. And actually, by systems, what I mean is that if we are comparing data or records which are coded in different ways, so for example, the way we talk about student mental health in universities, if we're coding using different scales from the scales that are used in the NHS, we've got to align and integrate those scales. We shouldn't have any excuse for not doing that. We've got to think about how we can use kind of common shared data standards and permissions across that gap. I mean, finally, I think the issue about how we share data informally, with informal support networks with family and friends, I think the student and student consent is at the heart of this. And there will be some very specific life-threatening situations where you might not need consent, but you should always come back to consent as the key point there. Sorry, I drifted a bit from the question, but I hope that gives you a sense of the range of the work that we're doing on those.
Yeah, absolutely, thank you. And for now, just one question for this block of discussion. How do you lift the taboo of mental health issues? Because staff and students might be inclined to ignore those who don't fit in.
Yeah, I mean, I think it's one of those kind of fundamental questions, isn't it? And you know, I should always say when I introduce myself, you know, I work in policy, which means that I know little about a lot of things. But actually, I'm not a specialist in stigma, or indeed in what stigma does in terms of help-seeking behaviour. But we do know from our discussions with people who really are specialists in this, and I would include Time to Change, which is the big national campaign in the UK and globally now, and also some of the leading academics in this area, that stigma, you know, there's no silver bullet for stigma. This is about kind of constant campaigning. It's about using every channel, communications channel that you have. It's particularly about empowering individuals to be aware and supportive. I mean, we in our slightly strange government response to the virus at the moment, we have a slogan which the government communications team have developed for us, which is hands, face and space, and that basically means wash your hands, wear a face mask, and stay socially distanced from people. And we think that you probably need hands, face, space, and be kind, because I think actually in the end, what changes lives with mental health and well-being is community and peer group. So I think getting everyone to see this as a priority. I mean, I'm sure you're aware of the phrase, we all have mental health, but getting people to really understand what that means on the ground with their peers and with their friends. If we can achieve that within 5 years, I would be very happy indeed. I think addressing stigma has got to go at all of those levels.
Exactly. Yeah. So I think because we have 10 minutes left officially, so maybe you can go ahead with your presentation first, and then we will see how many times left for some questions.
Brilliant. So I wanted to pick out actually just very quickly a couple of areas of strategic priority, but I don't want to miss the chance to hear from you about your experience of COVID and the pandemic. So I'm going to run through these quite quickly, and maybe Marjolaine, I could run through these next two sections together, and then we could have a discussion after that. It's a real focus again in our work at the moment, thinking about well-being along the educational journey. So before university, into higher education, induction, progression within university, because we often forget about that, and then really important, graduation, because we know that there's a real dip in well-being when people leave university and look for work. So I won't go into great detail on that. I think I would say this is something that needs to be a focus. I think we're still pushing government to join up along this journey, and universities are only one part of the answer to this. It needs joint work with schools and employers as well. And then finally, a particular focus of mine, and I would strongly recommend those of you who haven't already, looking at our linked framework, Minding Our Future, which I put a link to earlier in the presentation, which looks at partnership with the NHS and the kind of conversations that need to happen. Strategic links, of course, between vice chancellors and health system chief execs, but also those kind of ongoing operational dialogue and needs assessments, which are these effective working relationships, which are really critical to reducing the gaps in care. And we've all been there with these. We've all seen the students presented at an emergency department late at night after an episode of self-harm, were kind of kept in for a couple of hours or 3 or 4 hours, and then sent back without any notification to the university or to the accommodation. I think we absolutely have to look at these effective working relationships. And as we've signaled already, data sharing is critically important with that. One thing that we're looking at the moment, which I think is really promising, is about how the NHS, given this is such a significant population now, about how the NHS and care services can co-locate services where there are concentrations of student populations. We're running a pilot program at the moment. We're running a lot of pilot programs, but this one is 5 big university cities across the UK. Bristol, Sheffield, London, Liverpool, Greater Manchester, thinking about how we improve those partnerships. And in Greater Manchester, the 5 universities in Greater Manchester have worked with the local health service to set up a specialised NHS student mental health service that now takes in all student mental health issues that the university doesn't feel able to deal with. Again, happy to answer questions about that. I'll go on quickly to talk about the pandemic and then give a chance for closing discussion. I don't have a detailed slide on this because I think we're all kind of understanding impact and appropriate response, this week, last week, next week. But I mean, I just want to suggest a few things to you. First of all, clearly, I'm sure in Holland as well, like here, you talk about flattening the curve of the pandemic. So controlling the curve so that you don't overburden the health service. We need to do exactly the same thing with the mental health curve, the mental health impact of the pandemic. We know that the impact of the pandemic on young adults has been particularly severe in terms of their well-being. We know that it's presented particular challenges in terms of isolation, in terms of domestic abuse, and in terms of dislocation from their usual support communities. Now, those in themselves are not mental health conditions, but they might be precursors of chronic mental illness. We know also when students came back to university, as from our research, they desperately wanted to do, they wanted to be out of their family homes. They wanted to start living their lives. They understood that the pandemic was important, but they also understood it didn't really affect them, that they were much less likely to have severe outcomes from catching the virus. But we know that as they came to university cities, particularly in the north of England and in Scotland, where there were high rates of the virus, they were locked down in their accommodation. And there were again some really big mental health risks from this situation. Now, we've asked universities to step up to this and to set out, and I can share this, I haven't put this on here, but we've set out a checklist of how students must be supported if they're self-isolating, whether they've tested positive or whether they are a contact from a positive student. And mental health support is key in that. We're expecting universities to reach out probably on a daily basis with phone calls and other nudges to make sure that students are doing okay, to make sure that students feel able to ask for help. We're also doing a lot of work on practical support, food, laundry, all the rest of it for these sometimes quite large groups of students who are locked down and self-isolating. So that's the first group, which I think we've been thinking about a lot. And we're thinking about their mental health now, but we're also thinking about the long tail of impact of this pandemic and how that might work through, how post-trauma might emerge in the months and years to come. If I'm honest, I think one of my main areas of concern now is on staff. And I think staff who have worked without a break over the summer, who have just kind of put extraordinary efforts and resource, and I'm talking about academic and teaching staff, but also, of course, the professional services staff and support staff. There has been incredible efforts put in, and I think, as I said earlier, I think staff are fatigued and need additional support at this time. They also need for this work to be recognised, and those structural changes need to be made to do that. So, I mean, just to give you a concrete example of that, before you ask me to give you a concrete example, Marjolaine, is we're asking universities to give staff additional days off in the run up to Christmas, so longer Christmas holidays and additional breaks along the way as well, just because we know how hard they're working. I'll stop there. There's lots more to say about the pandemic. And in fact, if I'm honest, probably 4 out of, well, I was going to pretend that I only have a 5-day working week, but let's say the majority of my week is taken up with pandemic response at the moment across all the aspects of it. So I lead on the pandemic response at UUK, but really interested to pick up from those previous areas, or indeed anything on COVID as well. I'll stop there, Marjolaine.
Okay, thank you so much. We're almost running out of time, but maybe just a couple of questions, maybe with some short answers, and then we will finalize the discussion. One is about working together, like with the government, high schools, primary education, and to work together to establish like a healthy society. Can you add something about working together between the different parties?
Yeah, I think this is, I mean, as I think I said, of all the bits of our whole system framework, this is the one that we really do need to focus on now. And I think this is particularly true with the freshers, the first years coming into university now, who I don't know if you saw in the news, but there was an absolute disaster in England about the awarding of the results of the A levels, with lots of students being given one grade and then it taken away and then given another. Lots of students lost their places at universities, had to go to different universities, and the transition suddenly became an area of focus for government ministers. And so we have used that actually to say this is more important than just this year and us helping you out of the ministerial hole that you've dug for yourselves. This is more important than that. This has got to be about a strategic view across, I would go back, Marjolaine, to early years where so much of mental health and well-being is instilled, how we support families in early years, how schools embed health and well-being, how that transition into university and adulthood is managed, and indeed how the transition into work is managed. This is that I don't have any quick tips on this because this needs to be, it's a lot of big strategic asks here. And one is that in really simple terms, the departments of health and education need to work together in our governments to really focus on this. And I don't know about Holland, but I know here it's incredibly hard to get two government departments to work together. So we're on the early stage of that. But when Holland shows the example of how this should be done, we will we'll invite you to come and give a presentation to our community over here.
Yeah. Okay, yeah, I think we recognize what you're saying about the different departments. I think we have to go to an end of this session, and there were just a couple of questions left about things in the UK, like trends and things you see right in your country. So maybe that's just I propose that maybe some questions in the chat I can send to you via email, and maybe you can add 1 or 2 slides to your presentation to answer their questions. Would that
Brilliant.
be possible?
Yes, of course.
Yeah, perfect.
If I know the answers, yeah.
Absolutely. Okay, that will be great. So let's do that. And for now, we will end the discussion. In the chat, you will see like a lot of thank yous already about they really liked your presentation. It was really inspiring, interesting, I think. So thank you so much for this contribution on behalf of all the participants and also on behalf of ECIO. And for now, this was it. Have a good day, everyone.
Marjolaine, thank you very much indeed, and thank you all for inviting me to this discussion. And I mean, this is a shared endeavour that we're in. So I wish you all the very best in your critically important work over there. And let's keep in touch about this because we're all in it together.
Absolutely, yeah. Thank you so
very
much,
indeed.
and take care, everyone. Bye-bye.
Bye.